The one thing you should keep in the top of your head, that the single most important thing to remember about ethics is informed consent and the patients first. Now, we as doctors are not allowed to tell people what to do, and sometimes we just tell them too much. Now, those sayings don't come from me, but they come from our guests. My name is Stefan Reinhardt, Director of Education for the C.L.E.A.R Institute, and along with my co-host and friend Jerry Sampson, let's meet with Dr. Larry Jerrold. Jerry. You know how much I love to do these podcasts, how much I mean, we're enjoying ourselves, but this one is, it's, it cannot be missed. I mean, what just happened here, Jerry?
Well, Larry Jerrold that we're going to be talking with during this odd couple, he fits right in because he could be the third person, the odd couple. He's a odd and very interesting and well-educated person. Larry is not only a dentist and finished his orthodontic training, his formal orthodontic training, but he's also an attorney. And he has a degree in ethics in the humanities from Columbia University, and he has that advanced training. Also, Larry is the editor every month in the American Journal of Orthodontics for an interesting, catchy column called Litigation. He is definitely considered one of the experts here in the U.S. In legal aspects of dentistry and law. Now, I wanted to ask you something, Stefan. Based on our interview, were you surprised by some of the things that Larry had to say, some of his opinions? And
not only was I surprised, but I learned things. I was surprised, and some of the things he said, I said, "Whoa, I didn't know that." So I learned, and I really think that all dentists should listen to this. All team members should listen to this because it's. We talk about how to deal with patient, informed consent, all these things. All the team, everybody working in the office should know about this.
Well, one of the things that if you can soldier forth and make it all the way to the end, right at the conclusion, Stefan and I talk with Larry about the internet, and the main thing that we should all be concerned about is having bad feedback on the internet and getting slammed through Google or whatever the venue is. But I was shocked, and I think you were too, Stefan, when he talked about how it is actually possible to intervene or avoid bad feedback. But that's at the end.
You're in for a treat.
Enjoy yourself. I'm sure you will. Larry Jerrold with the Odd Couple. Larry Jerrold.
Yeah.
A remarkably interesting and uniquely qualified person. Larry, I think everybody that's watching and or listening is aware that you are a university-trained orthodontist, but you also have a law degree, and that's something Stefan and I are quite curious about. How did you make a decision to pursue that and get a formal law degree, a JD?
Let me include the ethics in that answer too.
Yes.
Because I have a certificate in bioethics. So in New York State, they have a very interesting dental political setup. And each county, of course, has their local dental society. Not each county, each area. And one of the committees in each dental society area is the Professional Liabilities Claims Committee. We lovingly refer to that as our malpractice committee. And it acts as an arm of the defense, okay? So that anybody who's insured by a state-sponsored carrier has to have their case, who's being sued, has to have their case heard before the malpractice committee. And we act as an arm of the defense. We have like 4 general dentists, periodontist, an oral surgeon, orthodontist, and endodontist. We all sit around this big table and we listen to the case. We've all received the Gutenberg Bible worth of papers before the meeting so we can go through all the records and everything. And then we recommend to the carrier, you really ought to settle this case as a dog. Or, you really should defend this case. And the carrier, of course, has the option, depending on which is going to be better for their bottom line, to settle or defend. But if we say defend, they must defend, no matter what it costs them. Okay?
Okay.
So my grandfather, for those of you who don't know, I was the world's first third-generation boarded orthodontist. Okay? My grandfather started the malpractice committee in Nassau County. And after he died, my father became the head of the committee. And after he died, they said, oh, shit, we got to have a Jerrold on the committee, So I became a member of the committee. And now it's the late 70s, okay, early 80s. And dentistry had just encountered its malpractice crisis. Medicine had gone through it in the early 70s to mid 70s. It's now the late 70s, and dentistry is encountering it. And my malpractice rates went from $300 a year to $3,000 a year. All right? So the Dental Society, in their infinite wisdom, decides, we should give risk management courses to the membership. And so who better to give the courses than the malpractice committee? So I'm up there in front of hundreds of people talking about risk management, and I realize I don't know what I'm talking about. Mm-hmm. Okay, I didn't know the law. I didn't have any formal training. I'm just spouting whatever the defense attorneys are telling me to say. Okay, and I hate not knowing what I'm talking about. So I went to law school. And that's a very interesting proposition, because this other guy on the committee was, I think, the first dentist attorney in the United States. Okay, Bud Pollock. He became the dean of Stony Brook Dental School. He's written books. Yada yada yada. He's dead now, but anyway, he's the one who kept telling me, you got to go to law school. You got to go to law school. You got to go to law school. And he invited me out to dinner one night. I'll never forget it. We were at the Danforth Inn or something in Port Jefferson. I remember I was having rabbit for dinner.
Rabbit?
Rabbit, yeah. And Bud opens up his briefcase and he pulls out a completed application to law school, because he had my CV. So he filled out the whole thing. He says, sign it. Okay. And okay, I signed it. Took the LSATs, blah, blah, blah. Got into law school, fine. So now I'm a orthodontist, and I'm
and you're practicing at this point, you're practicing orthodontics.
Oh yeah, I went to law school at night. Okay.
Okay.
I would
That was busy.
I'd get up at 5 o'clock in the morning, okay? I study for 2 hours. I go to the office, work until 5, drive to school. School was from 6 to 10. Came home, passed out, did the whole thing all over again. Did that for 4 years. So now I'm a lawyer. Now, I was teaching at NYU at the time, and all of a sudden they say, oh man, we got a guy who's a dentist, an orthodontist, and an attorney. Let's get him to teach ethics. Mm-hmm. Okay? Ethics. Okay. So now I'm, getting articles on ethics, and one day I'm in a copy room, and I'm copying all of these articles for myself to prepare my lectures and stuff. And there's this kid waiting there, he's bouncing up and down. He's waiting for me to finish at the copy machine. He sees what I'm doing. He goes, "Oh, you must be that new guy that got to teach us ethics. Dentistry and ethics. Didn't know it went together in the same sentence." And I looked at him. And I said,
Frequently they don't.
so I said, "Yeah, and then I started teaching.
That's like ethics and politics. That doesn't go together.
So I started teaching ethics, and I realized I don't know what I'm talking about. Okay, so I went back to school, took a certificate program, was sponsored by Columbia University and Montefiore Medical Center, and that was a year-long course, and then that's how I
Wait,
came about with law and ethics.
I have a question.
Yeah.
Uh, um, Ethics.
Yeah.
If you were to say this is the single most important thing to remember in your career about ethics, and by the way, for those of you watching and listening, this is not rehearsed. Larry doesn't know what we're going to talk about. Stefan and I rarely know what we're talking about. So, what would you say when it comes to ethics? This is something you need to keep in the top of your mind over money. Yes.
Mm-hmm.
Informed consent and the patient comes first. That's it.
That's it.
That's it.
Now you have having been quite good friends for I don't know, what are we on, Larry, 15 or 20
30 years? Yeah.
Yeah.
How did you guys meet?
In a taxi cab.
For real?
For real. We were at an airport going to an AAO meeting, and Jerry grabbed the cab in front of me, and he turns to me and he says, "You want to split the cab?" And I said, "Sure." And got in the cab and we started BSing, and that's how we met.
Okay, wow.
Now, you have told me a number of times, which I think is well worth repeating, that we as doctors are not allowed to tell people what to do.
Yeah.
And doesn't that bridge into this ethical question?
Yeah. Well, look. I was just reading an article a couple of weeks ago, and this doctor was psychiatrist was talking about this, and he said that patients always want the control. They want to control what treatment they receive and what they're going to agree to do and blah 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 blah. And so you tell them all of this information, and all of a sudden they start to suffer from information overload, and they really don't. They haven't been trained. They don't know. Okay, and now they turn to you and they go, "Well, what would you do, doc? What do
Yes.
you recommend?"
Yes.
Okay, and the bottom line is sometimes we can give them too much information. We can tell them too much, right?
Mm-hmm.
So it's fine to say up to a point that we give them information, and then they give us their consent / informed consent, and we can move forward until it gets to the point where, okay, doc, what do you recommend? What do you think I ought to do? And now the burden really shifts because you have to put yourself in the position of the patient. They've said, I want you to act for me.
Mm-hmm.
And so when you're now acting for me, I don't know what your income is. I don't know what your priorities are. I don't know what your value systems are. I don't know anything about you. So I have to learn a little bit about you as a patient to be able to make that decision for you. I know what's in my best interest as a dentist.
Yeah.
I know which procedure is going to net me more income. I know which procedure I'm better at. I know which, blah, 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 but I don't know anything about the patient. So.
But isn't there also, Jerry, Jerry was saying, I remember when I started taking courses and going to his lectures, and I don't know if it comes from you, Larry, but I remember him saying, when a patient asks you, what should I do? What should I do? And Jerry was always saying, I don't know what you should do. I can tell you what I would do, but I can never tell you what you should do or what I'm not you. And, I have dentists sometimes telling me, I have a golden rule. I always treat people, my patients, like I would want to be treated. And I always think it's wrong, because I think we should treat our patient like they want to be treated.
Correct.
Not like I want to be treated, because it may be completely different.
Probably, Stefan, the most important thing that I try and drive home is we can all tell our patients about the benefits they can expect. Okay? But it's far more important to tell them about what we can't do as opposed to what we can do. And that once you start to tell them about the limits, okay, the real limits, and realistic expectations, longevity, discomfort, what they have to go through, time, effort, responsibility. Once we give them the real negatives, okay, they can now start to make some real decisions. Everybody can paint rainbows and blue skies and white puffy clouds. It's the guy who's able to explain about the storm clouds on the horizon, okay, and get the patient to appreciate that now the patient's in a much better position to be able to make that decision with the doctor.
Well, how would you answer this that I've heard countless times but if I dwell on these dark clouds, and that I'm going to blow the patient out of the office, that they won't accept treatment. What's your opinion about that?
Well, I mean, there are artists who know how to paint, and there are people who think they're artists. And you have to know how to paint it. You have to know the words to use. You don't have to know how to present it. But I mean, listen, you're gonna tell somebody who comes in with short root anomaly, okay, and significant periodontal problems and compromised crown root ratio, and this is before you even touch them, okay, and you're not going to tell them about, hey, we do this, and I'll do it if you want to do it, but we do this. There's a significant chance you may lose some teeth here. You're not going to tell them that. I mean, for real, okay? And you can always say, listen, if it happens, we can fix it, we can deal with it, yeah, but you got to tell them about it, okay? It's the way you paint it. It's the way you talk to the patient.
Well,
I think it's good. I think it's maybe easier in these cases where you really see something. I think what's harder is when you have your general informed consent, and you have to talk about all these things. Like when you go to the hospital, I mean, you can always die, and so you can have root resorption. But it's true for all patients.
Yeah, I mean, you hit the nail on the head, because what most docs don't realize is that you got this 6-page pamphlet that you throw at somebody and say, okay, sign this, and then you think, okay, I'm good. But informed consent is a dynamic process. It constantly changes throughout the course of treatment. As clinical presentation changes, it's your obligation to say to the patient, hey, look, this is occurring. This is happening, okay? We got to discuss this. We got to figure out where we're. You may have to change treatment plan. You may have to cut short treatment. You may have to discontinue treatment. You may have to do a whole lot of things that you didn't discuss at the beginning, or if you did, it was so overbroad, the courts refer to it, it's so overbroad that the patient didn't know it applied to them, okay? And that's the problem, okay?
Yeah, I remember one time in one of your presentations you mentioned, think of informed consent as having an ongoing conversation.
Yeah.
That it is not a one-time event.
Right. Yeah.
And where I see people stumble tremendously is that they don't keep the patient updated in a timely fashion. And of course, the two biggest risks that I see that I think you and I have talked about, Larry, are decalcification, uh, decay, and periodontal problems, and extended treatment times. That those are really things that people can go ape over.
If you asked me what are the bullets on my hit parade, okay, I'm going to talk about white spot lesions and what comes after them. Okay, the decay, the decalcification, so on and so forth.
Yeah.
I'm going to talk about periodontal breakdown, okay, which comes from poor oral hygiene, but also overexpansion, compromising the buccal plate, the support, so on and so forth. Periodontal breakdown. I'm going to talk about root resorption. I'm going to talk about not telling them about the skeletal component to their problem and not offering alternatives to deal with that. Okay, and I mean those are the four bullets on the hit parade.
Where do you think that TMD, temporomandibular joint
Oh
problems,
man,
fall?
that's down the road. That's nonsense. I mean,
Okay.
yes, it happens, but it's not. Orthodontics is TMD neutral. Everybody has shown that. You know, if you got the wrong patient, stars and planets are aligned just wrong, it's going to happen whether it's a non-extraction case, an extraction case, an orthopedic case, in this case, wrong patient, wrong time, wrong karma, it's going to happen.
So
Um,
what should we answer? The question we have a lot of time from patients is, doctor, do I need a treatment in ortho?
You don't even need teeth. I tell everybody that. Okay? Look, in today's
Oh, I
society,
like that.
we don't need it for survival
Yeah.
anymore. Okay, but if you want teeth, and more importantly, if you want nice straight teeth, okay, yeah, that's what I do. It's what I can give you.
we don't
Okay,
need teeth,
but
but we do need a diastema.
yeah, you don't need it. So no, you know what? I can't tell you. I tell this to my residents all the time. I cannot tell you the 50, 100, 200 more times that a patient has turned to me and said, Doc, I just got to tell you, thank you. Nobody has ever taken the time to explain that to me. You've been so honest, okay? They just, you don't drive patients out of the office by being honest. They really appreciate it.
One of the things I want to drop in here that's one of my grand standbys, not in small part, in large part, I'll say because of my friendship with you, Larry, is when I'm picking up that a patient slash parent is just not all on board. If I'm not seeing a lot of this, and they're asking questions, which I always think is good, but they do not listen to the answer. That type of person, they're thinking of the next question. The first thing I say to them, Larry, is, if you'd like to get some other opinions, it's a great idea. Please don't think it'll bother me.
I give them names.
Yeah.
Yeah, I tell them, listen, I can see you're uncertain, okay? I see you have questions. Do yourself a favor. Do me a favor. Please go get a second opinion, okay? Here's some names of guys in the area that I realize, and gals, politically correct.
Okay, okay.
And after it's done, after you go there, okay, please come back so we can discuss what they said versus what I said. Okay, and I want you, even if you don't have treatment done in the office, I want you to understand your problem and how it can be fixed, regardless of who's going to do it. When you do that and you say that, they're coming back to you.
Yeah.
They're coming back to you.
We want to, one of the things we want to focus on with this groundwork that's been laid is one of the incredible shifts that's happened. It was on the horizon anyway, that being teledentistry. That was on the horizon, but now with the pandemic and the realities that we are facing, which many of which are going to be permanent, Stefan and I are exceptionally curious about your thoughts uh, and realities of teledentistry.
Yeah.
It's a tool.
Uh-huh.
It's a tool that can be used in specific situations. It's a tool that can be abused if it's overused. Okay. It's a tool that has the potential to do the patient harm. Okay. Um, there are certain things you can see and accomplish via teledentistry, and there are certain things you cannot see and cannot accomplish via teledentistry. I really doubt that you can get that far back in the mouth to see some transverse issues dealing with some of the posterior teeth via teledentistry. Is that important? I don't know. We could argue for the next 20 years whether a crossbite in a second molar is important or not. Okay, but whether you're going to pick it up with teledentistry, I doubt it. Okay, are you going to be able to pick up subtle differences in the character of the periodontium via teledentistry? No. Okay. Are you going to be able to you know, certain impacted teeth? This is another thing we'll get into. But in the old days, when we used to have plaster models, okay, and you could actually feel, okay, little bulges, okay. There was a certain tactile sense. It was just another piece of information you were able to put up into the computer, okay, to figure out every. You don't have that with teledentistry, okay. Teledentistry is great, except when it isn't.
Is it a fair statement to say in any type, not just teleorthodontic dentistry, but teledentistry in general? Is it a fair statement to say what you are really doing with a virtual visit is deciding, do you actually need to see the patient in the office? Is
That's
that is
another
it a
thing.
fair
Sure.
statement?
Yeah. Yeah. Absolutely.
And
This is
then,
how I see it. I see it as a first contact also
Yeah.
to just see
Yeah.
if it fits.
Yeah.
You know, yeah, are you a good fit with the patient?
Yeah.
Is the patient a good fit for you?
Yeah.
My opinion is that exactly it can never replace what we can do with a patient at the
It,
chair.
it's a good way to screen out the crazies too.
Yeah,
Yeah.
yeah,
that's it.
for those of you that are listening and watching this, if you're one of the crazies, then we've screened you out.
Oh, we may be the crazies they screened.
Yeah, no, that goes
Yeah,
for sure.
that's it. Have you seen, Larry? Have you seen a difference with um, with the Google University now? No, patients knowing more than us how to do things, and because of all the research they do on, they come with a certain maybe misconception. Is there a difference to what it was before when there was no Google or no?
Well, I would say it makes going to medical and dental school easier for the layperson. Okay. So I have a little postnasal thingy, and I always felt like there's something in the back of my throat. I don't know what the hell that is. So I go to the ENT guy, and he puts a scope down my nose, and he goes, "Oh, you have a thorn wall tumor." I'm like, "Oh, all right." Now, first thing you do, I encountered it during my general practice residency as well. Somebody tells you got something, you run to the medical library and you look it up. It's called medical student syndrome. And all of a sudden you have 13,000 things wrong with you. You're going to die next week.
Mm-hmm.
So I'm looking up this thorn wall cyst, tumor, whatever it is, and I'm using Dr. Google like everybody else. Okay.
Mm-hmm.
And I don't have any problems because it's a good way to get some basic information. The problem is when there's so many sites, you get exposed to a lot of biases which may not be 100% accurate. And so you're now the layperson, and this guy is telling you, you can do this and you can do that, and I can, and great, wonderful. They're getting all this information, and it may not be good information. I wrote an article just the other day, and in it I said, look, the AAO, the orthodontic community, we may not be providers of all of the information, but we need to be the providers of the best information. Okay? And that's the same thing with Dr. Google. Okay? Dr. Google will give you, I mean, you can go to the Mayo Clinic and look up this, and you can go to any major university, Johns Hopkins, all of these big places, and they all have information about everything in the world. Okay? But then it's like what we talked about 10 minutes earlier. It may be overbroad. It may not apply specifically to you. This is where the rubber meets the road, and you really have to have that one-on-one with the physician who's treating you, okay? The orthodontist who's treating you, the endodontist, periodontist, general dentist. Unless you have that, something's missing big time.
When you
teledentistry doesn't quite cut that.
Doesn't teledentistry what?
Doesn't quite cut that, Jerry. It comes close, but it's not.
Yeah, I think that it when the pandemic hit, Stefan, as I think you're aware, Larry, is very involved and I will say quite expert with clear aligners. And he did a YouTube information which had a lot of hits about clear aligners and the pandemic. And this is one of the things that seems to make the clear aligner approach very attractive.
I think it's great for clear aligner therapy. I'd say in probably 80% of your visits under clear aligner therapy, you could do that virtually.
80%?
Yeah.
Really?
For clear aligner therapy.
Yeah.
That's a big number. 8 out of 10 visits.
Yeah. Okay, yeah, you can go to your next set of trays. Okay, yeah, you know what? Whatever it is, and even as you said earlier, Jerry, it's that important visit that you see on the screen that says, you know something, Janie, I need you to come back into the office.
Yeah.
That's what virtual visits are. Hey, I don't need to see you. Yeah, I need to see you. Now you're going to miss some stuff. You make some mistakes, but that's okay.
How do you, Stefan, since you're more involved with clear aligners, how do you feel about it?
I'm surprised to hear that, but I presently would not be comfortable doing that. Doing 80% of my follow-up visits. For me, it's a tool for. I'll give you an example. I'm in Montreal. We have snowstorms. So I had patients, they couldn't come because they have a 2 hours drive to come to the clinic. And because they could not come, then we could do it virtually. We could do this follow-up appointment virtually. For me, presently, this is what I use it for. I would not replace it.
Could they go 2 or 3 months?
Oh, yeah. I see it as a tool, again, for, let's say I have a patient tell me, I lost an attachment. Well, instead of coming, we can just maybe do this virtual thing and just show me, and I'll see if you really need to come or if we can wait for next appointment.
Yeah.
For me, that's the use, but I would not replace again because I'm probably again in that generation where I like to feel. I like to touch. I like to look. I like to look at the second molar if they fit well. And those things I cannot see virtually. I can have the opinion of the patient.
Right.
One of the things you mentioned in the past, I think, that fits in with this line of discussion is you described orthodontics, Larry, a while back as we're in a certain type of business in orthodontics. We are not, you said, in the correction business. We are in the
Improvement business.
yes.
Oh,
Would you elaborate on that for us?
Yeah, I mean, look, the most important thing you can ever teach anybody who's going to start doing orthodontics is that you can't hit a home run with every case. Okay, you are not going to get a perfect result with every case. And so once you realize that, okay, you now have to go to the next step and say, what we do is make the abnormal normal. And what is normal? Normal is not a point. Normal is a range. Okay, and so you put snaggletooth, okay, and you make them into a normal dentition, which may have a 10 degree rotation of this and a millimeter labiolingual spread of this tooth and so on and so. It's not perfect. You know what? Even if it was perfect, it ain't going to stay perfect. So we're in the improvement business. We're going to make it a whole lot better than when you walked in.
How do you feel about this common thing happening right now that is really gained momentum? That being with orthodontists as well as non-orthodontists, but I'm going to say plenty of orthodontists that I've been hearing say things like, well, the patient was happy with their smile. They said their bite's comfortable. Yes, it's the midline's off. There's asymmetry. There's excess this. It's not really what I would call, from a dental occlusal standpoint, it's not ideal. It's outside of ideal, but it is functional. So let's get your braces off. How do you feel about that, Larry? It's basically, I'm asking you about limited treatment.
Well, I don't consider that limited treatment. I consider that a limited result. Limited treatment is you're addressing a particular problem when there are a whole host of other problems, and you're just going to concentrate on one or two. That's limited treatment.
All right, fair enough.
The diastema. Yeah, I may have a buccal. I may have a crossbite of my first molar, but I only want the space fixed. That's limited treatment. Okay. Limited result is a whole different ballgame. Okay. The fact that, as you said, the midline may be off a millimeter or two. Hey, what did Kokich's research teach us?
Right.
Midline deviation up to 3 millimeters is fine as long as the teeth are straight and they're not tilted. Okay, nobody's going to see it. It's not going to matter. Look at Tom Cruise, for Christ's sake. I mean, it's not a biggie. Okay, and again, as long as there's you said the magic words. As long as it's not dysfunctional, okay, I don't really have a problem with not being spot on with absolutely every marginal ridge, every whatever.
But who decides if it's functional or not? I mean, I have patients there. You look at them and you say it just makes no sense how they're biting and but they have no problems. And I have other patients, they're perfect class 1. They have problems. I always say the best articulator is the patient.
Yeah.
Am I wrong?
No. And look, can you eat okay? Can you eat all the food you want to eat? Yeah. You got any problems breathing? No. You got any problems? Okay. It's functional. And
so what if you finish with a patient and everything's good? 2 years after they come back and finally they have problems and they say it's all because they saw another dentist Or an orthodontist saying, well, of course, your midline's off, you have this and this and this. And they come back to you and say, well, finally, I
Well, the
have all
only
these
difference
problems. And
between you and me in that situation, I don't mean you, I mean
no, yeah.
whatever the you is, okay? The only difference between you and me is that when I finished the case, I told the patient about it. I told him the midline was off. I told him the bite was a little bit off on the left side, okay? The second most important visit any orthodontist can ever have is the consultation visit at the end.
Uh-huh.
Okay, when you have here's where you started, here's where you are, look at all we accomplished, and you know what? You got these two tiny little things that are out of sync, but not a big deal. We're gonna watch it. If there's any problem down the road, we can fix it. You have that post-treatment consultation, and nobody does it.
Yeah.
Nobody does it.
No, you're right.
It's critical. What they do instead, they give the patient a piece of paper that says, I'm happy with my treatment. The patient signs it, and that's the post-treatment consultation.
And here's your retention, and this is what you do. Because it goes back to what you were saying. It's like, it's still the informed consent. It's just the informed consent is a work in progress.
Yeah.
And it goes right to that
right
point.
To the end. Right.
Yeah.
Yeah.
Yeah, that I think that's absolutely stellar. And I am very aware, as is Stefan, that the vast majority of our colleagues do no such thing. As a matter of fact, I had a conversation with an exceptionally successful orthodontic business person whose comment was, "Oh God, don't show them that. Then they'll obsess over it." And I said, "Whoa, whoa, whoa, whoa! No, I have to show them that." And my comment to the patient/parent is, let me show you, as you said, Larry, where you started. Now hold up this large mirror so you can see this is where we are now. Mm-hmm. Now, someday, some well-meaning dentist is probably going to say, well, the reason you have this and that with the jaw, and it's because this guy Samson didn't finish your bite correctly.
Yeah.
And that is going to happen.
And Mrs. Jones, I wanna remind you of the 1,730 times you came in that Jimmy didn't wear the rubber bands and didn't brush his teeth and didn't do this and didn't, and it's all documented. One of the best, and again, you can't do this with computers. One of the best risk management tools ever invented was the Bic 4-color pen. Okay, where you click the things and you get the 4 different colors. Because my chart entries would always be in black or blue, didn't matter. Everything that was wrong was in red. Missed appointment, didn't wear this, didn't do this, pop. Whatever it was in red. Whatever I wanted to remind myself to do next visit was in green. Okay? And so it was all right there. And now when the lawsuit comes, okay, you're on the witness stand, it's so easy to say, patient, plaintiff, person who's suing me, here's a copy of your chart. Can you tell me what you see there? You know, a lot of writing. Yeah, and what colors do you see there? He said, oh, there, red, blue, green. I said, how much red, how much black? I think there's a lot of red. I said, do you know what red means in this office? Yeah, no, what does it mean? Red means every time you didn't do something you were supposed to do. Red means every time there was a problem, okay? And it's really, really important that we learn to document this stuff, okay? CYA kind of stuff. And it was great in the old days. Today, with certain computer systems, software systems, you can't do that. Once you start an entry, it's got to be in the same color you started. You can't mix and match entries. Oh yeah, you can maybe do some italics or some bold to differentiate it, but it's not as dramatic.
Talk to us a minute about in the red ink vein about patients where treatment should be discontinued and what your responsibility is. Like they've had numerous visits of non-compliance, including poor oral hygiene, and so on.
Look, Neil Sedaka said breaking up is hard to do. And it's one of the hardest lessons any orthodontist has to learn. You have to learn when to say goodbye. And when the patient is compromising their own care, okay, and you feel it's reaching a certain point that continuing it is going to be detrimental to the patient, that's the point at which you say, we're done. Taking the braces off, we're finished, okay? There's a difference between discontinuing treatment and terminating the doctor-patient relationship. Two different things. I see caries occurring, I see root resorption occurring, I see decalcifications occurring, blah, 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 blah. I may decide to discontinue treatment at that point, okay? And we may reinstitute it at a future point in time, but that doctor-patient relationship is still in existence. Once I decide to terminate the doctor-patient relationship, we're done. It's over, okay? And that's two different animals. People say, well, should I put in a retainer? You know what? Depends on the case. In certain third world countries where they don't have orthodontists and they had crowding, what did they do? They took out some teeth. They let Mother Nature do the orthodontics, okay? And if you're in a situation where letting high canines drift down on their own may be a benefit to the patient. I don't want to retain incompleted results. I don't want to retain results that I have pushed the envelope, and I don't want to hold teeth in an artificial position which is not stable. I don't want to put in retainers in that situation. Others I do want to retain.
What if the patient says, you say, look, we need to discontinue treatment?
Yeah.
And part of what I'm bridging into is it could be with clear aligners, because I'm sure there can be patients with hideous oral hygiene from clear aligners. So either way, what if the patient says, no, 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 I am not permitting you to discontinue treatment. I don't want you to do that in my kit, for example.
Okay, so you're getting into the area of autonomy, okay? And with starting on the patient side, the patient is an autonomous individual. They have a right to decide what will or won't be done, accept your treatment, not accept your treatment, so on and so forth. Once that's all established and out of the way, there is practitioner autonomy. You have the right to say, I'll do this, or nah, I'm not comfortable doing this, I don't want to do that. It's what gives Catholic physicians the right not to perform abortions. I don't believe in it, I don't want to do it. Okay? You can't force that. Well, you can't force me to do this non-extraction if I believe it's an extraction case. You can't force me to continue to treat you if I see this case going downhill and you're hurting yourself. If you want to continue treatment, patient, as an autonomous individual, you're absolutely free. Go someplace else. I ain't going to do it.
So under those circumstances, do you recommend a formal release of the patient from the office?
No, just say you're dismissed. I write it in the chart. Write the reason why. If they aren't in the office and I haven't had that conversation with them, then of course it's a letter, okay, that goes out. And there's 6 legally accepted reasons all across the country. Okay, I assume in Canada, since same legal system. Okay, that you can terminate the doctor-patient relationship, and the patient can't say boo about it. Okay, and one of them is the patient's not following instructions. They're harming themselves.
Now, as I recall from previous conversations, I just want to underscore this from your area, Larry, as the expert, is if you in fact are going to do this, or I should say when you are going to do this, rather than just keep dragging this on, you're going to discontinue the doctor-patient relationship. What is absolutely critical, as I recall from our conversation, is that the patient's record is impeccable. because they may come right back at you saying, "No, I didn't like you anyway. I'm coming after you."
Yeah.
You know what, Jerry? That's the reason you carry malpractice insurance. I mean, somebody wants to sue me. Honestly, I don't care. I honestly don't. I have malpractice insurance. I'm not afraid to drive the car to the office. I'm not afraid somebody's going to slip and fall on the icy steps. I'm not. That's why I have insurance, so I can sleep at night. I don't worry about that. You want to sue me? Sue me. Good. I'm done. I don't care. Okay. I know people who have had ulcers, kill themselves. Okay. I mean, they take it real personal. Well, yes, it's personal, but you know what? It's just business. Okay, it's a Michael Corleone thing. It's just business, Sonny. You know, and that's all it is. And you, at some point in time, 1 out of every 3 doctors is going to be sued once every 7 to 10 years. I mean, those are the statistics. So that's why you carry malpractice insurance.
It happened to me.
Oh,
It
really?
happened to me. I mean, what can you do? I mean, we were 3 dentists at the clinic, three partners. And we have a patient who sued the 3 dentists at the same time and sued the clinic. So we had like 4 things. And we went to this process of with the insurance and everything. And they said, there's no fault there. So we're going to fight. We're going to court. And you know what the problem was is that we had to close the clinic for a whole week.
Yeah.
It cost us, even if we, at the end, we
Yeah.
won, it cost us so much money at a time where we had no money.
Yeah.
And this was, and the other thing my experience with that, Larry, at the time is that, you know, we had the judge there who had no knowledge at all of what dentistry is. And we could see from the start, he was going, you know, with the poor lady who's, you know, making a complaint. But we had all the specialists from Montreal University backing up who were in court with us. And like I'm telling you, we finally win this thing. But I mean, the damage was there.
Takes a lot out of you. And today, it's even more damaging because of the internet.
Oh,
Oh, yes.
Oh my God. I am so thrilled I'm not in practice anymore. Okay. I mean, it scares me when I see these kids going out today. It's like going out into the Wild West. I mean, I don't know how I would do it.
well, that's something we wanted to,
Yeah.
Stefan and I wanted to ask you about is the power of the internet and free speech and what people can say about you.
Yeah.
Now, when someone,
And how to react to that.
Well,
how to react and how not to react. What's your
That's it.
look, we live in a free society, and I'm sure the same as in Canada is in the States. You have freedom to contract. Okay, you can agree with somebody else to do X, Y, or Z, and there's in contract law there's offer, acceptance, and consideration. So I offer to do something or refrain from doing something. You accept that. There's a certain degree of consideration, money that's exchanged at the quid pro quo. Okay, and a valid contract has been formed. If I was practicing today, okay, I would have a non-disparagement clause as part of my contract, okay? And I am
Okay.
not going to
Ooh.
treat you, okay? You're free to go anywhere you want, but I am not going to treat you unless you sign this. And it says you cannot go to the internet in any manner, shape, or form. You can't do this. You can't do any medium. You got the whole thing, okay? And in exchange, I'm going to give you $500 or $1,000 off the orthodontics.
Wait a minute, that's legal.
Oh,
That's
absolutely.
legal.
Yeah,
Really?
yeah. Nobody's forcing anybody to do it. Okay, you know, you
Well,
want
for those of you who are still listening or watching only for that, it was worth
now.
it.
Why isn't it legal? Okay,
I don't know.
that you're contracting. You're agreeing to do this. They're agreeing not to do something. In
But
exchange, they're getting this huge benefit. They can
so
still sue you, Jerry.
yes,
No mistake about it. They
all right.
got to.
Yeah, yeah, yeah.
That you're still allowed to sue me. I don't care about that. You just can't go to the internet and spew this shit all over the place. Can't do that.
But I would never have thought that it would be legal. Like, I see this a little bit like blackmailing, you know. So I'm
What?
giving you this. Yeah. So, but I'm happy to know that it's legal.
You're not blackmailing anybody because they haven't started treatment yet.
Yeah. Okay. Yeah.
You're not doing it once they started treatment.
No.
You got them in hardware and you're holding them hostage.
That would not be good. Oh, you know what? Finally, I'm just looking at you, and I think it would be good if we could just sign this little.
I'll take your braces off. Yes. So, but obviously, they could still. So now, let's say the patient agrees, they sign,
Yeah.
but then they slam you on the internet anyway. What would your
Well,
what would
there's a liquidated damages provision in this contract. It says
which means
if
what?
you do this, this is what the cost is going to be.
Okay.
So you're saying if they did it, that you would take them to court?
Yeah, absolutely.
Absolutely.
The same way you would take somebody to small claims court who didn't pay your bill.
So one of the things that I've heard about that's fact. This is not a story made up for emphasis. It's a fact that a colleague was really slammed on the internet by a patient, and the advice that the colleague received was to sue the patient for defamation of character, because they went on all kinds of stuff and
Yeah.
slammed this orthodontist. And then the patient's reaction was to go on the internet again and say, poor, poor, pitiful me. Look at me. I'm driving a used Hyundai. I can't even afford to buy a McDonald's wrapper. And this rich orthodontist is suing me. What's your
Yeah.
reaction to that?
That's why it's a scary environment out there.
Uh-huh.
Okay, but they have anti-SLAPP laws that are meant to address this. Okay, and there are certain state statutes and provisions that deal with freedoms of speech and where you can go and how far you can go and so on and so forth, which is why you want to head it off at the pass before it even happens.
Mm-hmm.
So it occurs to me that someone would be thinking, as I'm thinking now, all right, so you're going to have the patient sign this very clearly written clause that says that they agree in consideration of a fee reduction or something like this to not sue you.
No, not
Not to not sue you.
That,
No.
Not-
Uh-huh.
That's a whole different contract you can sign.
Yeah.
You can have that. Listen, there are doctors out there who require, if I'm going to treat you, you can't sue me. I have to go to arbitration.
And what do you think
Okay.
about that?
It's another way of doing business.
Yeah.
Okay? I don't look. I believe that I have treated all of my patients fairly to the best of my abilities. And like I said a little while ago, that's the reason I carry malpractice insurance.
Mm-hmm.
Shit happens. Accidents happen. Bad results happen. It happens. You have to own it. If you're going to be a clinical practitioner, you own everything that goes on in your office. You own it. Okay? Don't make excuses. None of that crap. You own it. And one of the things you own is knowing that every now and then you're going to make a mistake.
Yeah.
And it may be a diagnostic mistake, and it may be an honest mistake. Mm-hmm. You didn't see it, whatever it was. The mechanics you used were just wrong. There was one case I saw, more than one case. Wasn't enough room for an upper canine. Guy puts in a coil spring, okay, to open up the space. Teeth are going like this. Almost horizontal, like diving boards. Okay? Roots went back, palatal cortex, ton of root resorption, lost the anterior teeth, blah, 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 blah. Things are going to happen, okay? And you were just trying to open up space for the canine, okay? So, A, I got malpractice insurance. B, if I was really nuts and like Stefan, I didn't want to close the office for a week. I didn't want to be in trial. I didn't want all the aggravation. I didn't want the agita. I didn't want the ulcer. Arbitration. You got a problem? Arbitration. Okay, fine.
You know,
You want it? Fine. Go someplace else.
yeah, I can hear people thinking, I really can. Yeah, but if I haven't signed all this stuff, they're going to say, so you're afraid to treat me. You've had other problems. I don't think you're the person for me, blah, blah. And I think, Larry, I'm assuming your answer would be, fine, maybe I'm not the person for you. But I, quite a few years ago, I was friends, a very interesting friendship with a plastic surgeon. And we were talking about informed consent. And I bet, Larry, it was around the time when you and I jumped into that cab together. And this, when we were talking about, I'll tell you, his first name is Steve. So Steve and I are talking about this and plastic surgery, cosmetics. I mean, this is part of their education that it's not if, it's when you are sued. It is going, or when you,
right.
This is before the internet.
Yeah.
I thought he had something incredibly good, Larry. What it said was that he showed me what he had them sign. And it said, if you have a complaint, if you have a concern, all that I ask is that you talk to me about it first. That you don't go to another plastic surgeon. Talk to me about it first. That you don't go to an attorney or the state medical board. You talk to me about it first.
Yeah,
That's
I don't
all
know
that
that you can do that.
No, you don't like it.
No.
I'm not saying I don't like it. I don't know that you can require that.
Okay. You can ask for it, but it has no value, no legal value.
Yeah.
Um,
Patient always has a right to get a second opinion.
yeah. Well, but it wasn't a requirement. It was an ask. That's how. I mean, I remember
Okay. Well,
he was asking, just please talk to me first. You know, another thing that occurs to me about this is that I've been an expert witness, I think, 8 times. It might be more. And without any exception, it seemed to me that what triggered the problem is somebody got really angry. And that, in fact, the patient was treated rudely or not, the concerns were not addressed in a timely fashion. Had that been done, I don't think that there would have been a problem.
Yeah.
Do you agree, Larry?
Back in the late 70s, early 80s, and it's got to be true today. Things don't change. It was in medical economics. They did a survey of 1,543, I think, physicians about getting sued. And they listed the things that all the physicians got sued for. And one of the questions was, A, have you ever been sued? Okay. If the answer was no, skip to question, 14. If the answer was yes, then they got all this other data. And when they now had this tiny little pool of people who had never been sued, and they said, what do you think the reason was that you've never been sued? And these were people from all over the country, never spoke to one another, didn't know one another. They all had the same answer, the exact same answer: a strong doctor-patient relationship.
Yes.
Okay. Now, to get back to your question, when they we're starting to figure out why doctors did get sued. Okay, the number one reason on the hit parade, number one, be a jerk. Okay, now
Yep.
what's a jerk? It's like Justice Potter Stewart. I can't define pornography, but I know it when I see it. Okay, what makes somebody a jerk? Okay, I can't really define it, but I know a jerk when I see one. Okay, and when the jury sees that you are a jerk, you lose, and it's just that plain and simple.
Yeah.
You lose. Okay, and so it's this breakdown in communications. It's you're no longer on the same plane with the patient. That's when it happens. The famous Michigan case, Jer. Okay.
Yep. Oh.
Okay.
TMJ.
It is my understanding that what precipitated the actual lawsuit was that the orthodontist did not get back to the patient.
That's
The
my understanding.
treatment coordinator talked to the patient. The office manager talked to the patient. This person, the doctor, did not call back and talk to the patient. Okay.
Enter the televisit. There is no excuse if someone is upset. In my private practice, which I've stopped 4 years ago, the law of that jungle is we never let a patient or a parent get out of this office if they're upset.
Yeah.
Now, sometimes it would happen, but I would be on the phone with them to find out what happened from them, apologize,
That's
which
it.
is not an admission of wrongdoing. Isn't that right, Larry? An apology is not an admission of wrongdoing.
Correct.
It's an apology.
It's an apology. I empathize with you. I feel bad that you feel upset. Okay. So what was it? How do I fix it? Okay.
How do I
What can I
fix it?
do?
What do you want me to do?
Yeah, I'll go.
What can I do to help
what do
you?
you
That's
want?
it.
I'll
Yeah,
fix it.
great. My comment was, I have the power to fix this. And if you'll tell me what you think is right, we can fix it.
Right.
No laying of blame. You know, the misconception that if somebody in the office apologizes that something was done wrong,
Yeah.
the
You admit that.
And Jared, the second misconception is that if they say, well, I want some money back. And
Yeah.
that's the second misconception. You give money back, you're admitting guilt. No, you're not.
Yeah.
You're just
You're not.
trying to make nice.
So what
Well,
about that? If you give a money back, Larry, what should people? What's the appropriate approach if you're going to give the money back?
Well, you get a release.
Yeah.
Okay. You get money back, you always get a release. They're happy to give you back partial, total refund. Sign the release. Okay.
Okay.
And releases are binding, except on minors. Okay. Patient's a minor, mom signs a release. It's not binding on the minor. The kid reaches the age of legal majority, he or she can now sue you, even though mom signed the release.
Oh.
Ooh.
Oh.
Right. Yeah. There's
Okay.
All
Yeah,
of-
that's good.
all of this is. By the way, my asterisk footnote is this is why we deserve to be nicely compensated for what we do.
Absolutely.
Yeah.
Because
That's it.
the sword has fallen on us.
But if we all, I mean, do you have this saying that, no, I always say we all have these skeleton in our closet. You have this saying in French. And we all have these patients that, you just wish they will never leave the office. Because
I remember an oral surgeon friend of mine called clinical disasters horrendinomas, and I remember this horrendinoma occurring in the orthodontic clinic.
Horrendinoma.
Yeah, horrendinoma, and it was I forget whether I was a resident or I was a junior faculty at the time, but there was this older faculty member, and he's witnessing this whole thing, and he said, God, I wish I had 10 of those. And I turned to him and said, why? He says, because I got 50 of them. We all have skeletons in the closet.
that's it.
Yeah.
That's it. I mean, when you hear people saying the dentists or everything they do works, everything, I just say they don't do enough.
Yeah.
I mean, that's
nah,
the thing.
they're just lying. That's all.
Yeah.
They're blatant liars.
Or they just don't see it, Jerry.
Yeah,
That's
right.
the other thing.
The just something else that Stefan and I, in our planning session for our discussion with you, that has come up
You
is
had a session about
yes,
me beforehand?
only this is completely off the cuff, but Stefan and I did have a strategic session. It lasted about 45 seconds. So what one of our questions is, and this came up from a colleague, as in, and I'm not exaggerating, yesterday, when one doctor is helping another doctor, treatment planning, maybe a clean check for aligners, something like this.
Private consultation with a colleague.
What liability, if I am asking Stefan's help in a case, what liability does Stefan have? I'm treating the case, but I ask his advice.
Very little unless, okay? And the reason is that if you did not, and the courts have recognized this, they've written about it a lot, they talk about curbside opinions. And without curbside opinions, it would really inhibit medical care. Okay, you have to be able to turn to a colleague and say, "Hey, listen, I got a problem with a case. What do you think?" Blah 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 blah, and that's okay. That's not a problem. There's no doctor relationship between Stefan and you. I mean, Stefan and the patient. Okay, it's your patient. You talk to Stefan, but Stefan's never met the patient, never corresponded, talked to them. Patient doesn't even know his name. Okay, there's no liability without the existence of a doctor-patient relationship. Now, having said that, Stefan recognizes that you're the practitioner. You are going to use your independent judgment as to what you're going to do, how you're going to do it, when you're going to do it, and why you're going to do it. He is merely providing you with his expertise and input. It is some pieces of data which you will put into the computer on your shoulders, and you will analyze and come up with what you're going to do. Okay? On the other hand, you explain to your patient the problem they're having, and the patient says, "Well, what are we going to do?" And you go, "I don't know. This is. I haven't seen too much of this, but I got this friend, Dr. Stefan. Okay, and if you don't mind, I'm going to call him and see what he thinks." Okay, and the patient says, "Well, what's his deal?" Well, he's the chair of orthodontics here, and he's written 1 million articles on this, and he's the world expert on this, and I want to talk to him about this. And she says, "Okay, go ahead." And now you speak to Stefan, and what do you think I should do? Well, yeah, but explain that to me. How exactly should I do it? What are the steps? And you say, "Okay, that's exactly what I'm going to do. And you know what? Next time we meet in Montreal, dinner's on me. I'm going to take you out, okay?" And then you go back to the patient and you go, "Listen, I spoke to him. Here's what he thinks we should do, okay? He told me how to do it. I'm going to go ahead and do it, okay? Okay?" And you make a little joke with the patient. "I got to take him out to dinner. I'm going to add it onto your bill." You know, whatever light stuff you do.
Yeah.
And now all of a sudden you start to see the grayness between 50 Shades of Gray, okay? How much of a doctor-patient relationship did I just create or didn't I create? And once again, it gets to the line I always say, the stars and planets are aligned in just the wrong way, okay? You can create that situation where liability could attach. But 99% of the time, not a big deal.
Okay.
So what I have been doing um, and you correct me if I've misinterpreted your advice in the past, is when I give advice to people about cases, which, as you're aware, I do quite a bit of. I am not patient specific, even when I'm looking at the patient records. What I say is, and I do it by a voice recording, and now I'm doing it with Zoom as well for selected people. And I am being paid for this, by the way. So if that enters into to how you'll comment about this, Larry,
Who's paying you?
The doctor,
The dentist.
Not the patient.
doctor.
not the patient.
All right.
The doctor pays me for the consult. So I am not patient specific. What I say is, based on what I am seeing,
Is the doctor charging the patient an extra amount of money?
no,
All right.
not that I'm aware of.
You see the questions
That's
I'm
it. Not
asking
that I'm
here?
aware of.
I'm trying to find out if there's any way at all that there could be construed
Yeah.
doctor-patient relationship.
So, but what I say is, in similar cases, what I have found to be effective is, I don't say you should do this, do that, don't do. I say in similar cases. Now, I seem to recall a conversation with you, Larry, where you had mentioned that would be a smart way, that you're not patient specific, that you're breaking that chain of causality. Is that correct?
Well, I mean, look, wherever you can couch it as more universal as opposed to specific, the safer you are. But depending on the situation, it may have to be specific to these clinical findings or this particular patient. And that's just part of what a curbside opinion is. And that's okay.
Because we could see the same thing with you lecturing. I could go to one of your lecturer, Jerry, and say, well, I saw his lecture on class 2 div 2 cases, and he's treating it like this, and this is what I did, and it didn't work. So it's your fault.
Yeah. And, graduates have sued their professional schools, okay, for not having provided sufficient education or wrong education regarding X, Y, and Z. Okay? The cases usually don't go anyplace, but that's not the point. Okay? You're making the argument.
When a second opinion in private practice, I gave a fair amount of second opinions, as I think most people do.
Well, a lot of people, Jerry, will not do second opinion.
Yes.
A lot of people out there just won't do it.
For what
Really?
reason?
Yeah, they just don't want to be involved.
So when the patient calls the office, for example, tries to make an appointment, the person answering the phone, the front desk, would say, "Is this a second opinion?" Is that how they find out?
Yeah.
Okay, I want to hit one other thing.
Well, wait, I want to go back to your second opinion thing.
Okay, go ahead.
There's a right way to do a second opinion.
All right.
And the right way to do the second opinion is you don't have a dog in the fight. Okay? Patient comes in, second opinion. Lady, I'll give you a second opinion. I will not treat you. Now it's a real second opinion. Okay? And I don't want to know what the first guy said. Don't tell me. It's the only way I can give you an honest second opinion. I don't want to know what he said. You can tell me afterwards, okay, and then we can discuss the difference. I don't want to know what he said, and under no circumstances will I treat you. Now you're giving a true second opinion, and the patient's getting a true second opinion. And you charge for that.
And what about a patient? I have some patient, and that occurred a couple of times, coming from another country and just moving here. They're in an orthodontic treatment. So they arrive with their braces. Now I've been told by the board here, you do not touch that. But I cannot leave the patient like that.
Oh my God.
That's it. I never understood that, Larry. I never understood that.
So
But so we should leave the patient like that.
Okay.
And don't touch the patient.
Okay.
Why?
So I'm a cardiac patient,
Yeah.
and I moved from New York to California, and I need a new cardiologist, and he says, I ain't going to touch you. You've been seeing
That's
my
it.
own
Makes no
doctor."
sense.
How stupid is that? Okay.
Good.
And I can't tell you how many hundreds and hundreds of orthodontists who are out there who will not accept transfer cases. Will not. It's the most unethical thing I ever heard of.
Yeah.
Okay. Then they go on to say, well, yeah, I'll accept a patient in transfer, but only if they bring me the original records and this and that. Well, Tom Hanks in Castaway, the FedEx plane went down and the records were destroyed. Where does that leave the patient? What do you need the other records for? You don't need them at all. Okay? The patient comes into you, you examine the patient, you see where they're at, you decide autonomously, I will accept this case, I won't accept this case. I will move forward from here, get my new records, get whatever information I need, have the consultation with the patient, get the informed consent moving forward, blah, 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 blah. I mean, that's what doctors do. They treat people who have pre-existing conditions, okay? In any discipline of medicine. Why are we different?
I never understood.
It would be nice if I could get the original records, okay? Just as it would be nice when the cardiologist says, listen, can you get me some old medical records? Can you get me your operative report? But if I go, no, I don't have it, nobody has it, okay, they're going to treat you.
It's just your new starting point. This is where you start from. I have another example for you. Another thing that they tell us here is that, let's say you have a patient, 10 years, orthodontist, 10 years, the orthodontist, they did the treatment, doesn't practice anymore, whatever. They had a lingual wire comes out. They need a new one. They say, if you put the new lingual wire, you're now responsible of the case.
Well, am I doing this because they're on vacation and it's a one-shot deal where they came in with a broken wire and you're replacing a wire? Or is it that, you're going to be taking over the case? There are orthodontists who live in vacation communities, okay, and certain communities where they have a high level of transient populations for short periods of time. And a patient, you have a broken wire? Good, I take it out, I put a new wire in, goodbye.
That's it.
And give me the name of your orthodontist, I'll write them, I'll tell them what I did. Forget it, don't worry about it. Half the time, this would happen when, you know what? It happened, as an example, it happened a bunch of times, but 2 times I can remember was when Ringling Brothers Barnum and Bailey Circus came to Long Island at the Nassau Coliseum, and one of the kids had braces and lost something, broke something, and came into the office, and I replaced it, and there's no charge. Forget about it. Just
that's it.
Don't worry about it. I mean, come on. This is part of what we do. Just do it and move on. Okay?
Exactly.
So here is my last provocative question.
Let's go.
You are aware, as is everyone in the audience, that Stefan is a general dentist who really only does orthodontics these days. Doesn't only clear aligners, nothing
Whatever.
else.
Yeah.
What is we would like to hear what you have to say about.
I was not good enough in the other things.
Look, I don't have a turf issue. Okay, I've never had a turf issue. The first lecture I ever gave in my life, when I decided I wanted to go on the lecture circuit, was orthodontics for the general practitioner. Okay, I mean, I don't have a turf issue. When you graduate from dental school, you got your 007 license to kill, and you can practice any discipline of dentistry you want: endo, perio, oral surgery. Why shouldn't a pediatric dentist or anybody do ortho, as long as they are trained to do it. And it doesn't have to be in a university setting, okay? As long as they have the training and capability to do whatever it is they're trying to do at that point in time, I don't have any issue with it, because they, like me, like everybody else, is going to be held to a certain standard of care regarding their ministrations, whatever they happen to be. So I don't have any issues. Why should I?
This is always how I was seeing it, that, you know, we could do everything else. We could do endo treatment, we can do surgery, we can do, but it was like orthodontics, you cannot touch that. Well, for me, it makes no sense, because I can decide to do endo only on centrals, anterior teeth, and refer all the molars. Well, it should be the same thing with ortho too. I could decide that I want to treat cases who are perfect class 1, good occlusion, no vertical no vertical corrections to do. Or I think the problem is, and this is exactly what you said, is that some dentists go to a half-day course on orthodontics or clear aligners, whatever, and they think they can do orthodontic treatment. And this is where the problem is. And you cannot learn to do orthodontic in a half-day course. It's like anything else. You will not go to do a half-day course and place implants.
There are only two things you need to know to be an orthodontist. Only two. And the first day of every residency year, okay, I say this to my residents. The problem is you will forget these two things, okay? Every action has an equal and opposite reaction. Two things cannot occupy the same place at the same time. You are now an orthodontist, okay? And that's what I tell them. That's it, okay? Everybody forgets that. Guys who've been in practice for 20 years forget that, okay?
Did you just make the sign of the cross? How does Mrs. Jerrold feel about that, Larry?
The last thing I do is I throw in a bit of Zen orthodontics, which is be the wire, be the tooth. You know, the wire always wants to go back to its neutral position, okay? And so it's flexed and doing whatever. Be the wire, okay? Be the tooth. The wire attaches up here. This goes down. These guys go up. It comes out. These goes down. But that's all you have to remember, okay? And they don't remember it. They just don't remember it.
How important is it for non-orthodontists to make sure that the patient/parents are aware that they're being treated by, let's say, a general dentist or a pediatric dentist or a periodontist?
If you were doing one of your first implants, would you tell a patient you're doing one of your first implants? If you were doing one of your first perio surgeries of some type with guided tissue regeneration, would you tell the patient, this is the first time I'm doing this? No, you wouldn't, okay? You would, if they ask you what's your experience, what's your expertise, whatever, then you got to tell them, okay? But you certainly wouldn't offer that. And I don't think somebody who's starting to do ortho would have to either. But the wisdom is that you start off with really simple, easy cases, okay? Or at least those that appear to be really simple.
Well, that's it. The wisdom is being able to know which cases are.
Maybe, okay, listen, I had oh my God, I've been friends with the guy for 40 years. General dentist. When I first went knocking on doors when I was a little pitcher, and I'm going to all the general dentists. I'm the new orthodontist in town, blah, 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 send me cases. And he says, well, I sort of like to do a little ortho myself. And I said, that's great. Anytime you want to discuss anything, got any questions, feel free to call me, okay? And every now and then I would hear from him. We've since become very, very close and yada, yada, yada. And over the 40 years, he started doing less and less ortho than when he was, a younger practitioner. But it's fine as long as you have support, backup, somebody you can call, somebody you can go to. Why wouldn't you do this?
But
Don't you surgery?
Don't you think, Larry, that one of the problem is that there are not enough Jerry Sampsons out there teaching general dentists and podiatric dentists how to do the ortho? I think one of the problems there. I have no problem going and getting education on endodontics, on surgery, on periodontics. The problem I have is finding people teaching that know what they're talking about and teaching about ortho to general dentists.
Look, orthodontics has been very good to me. It was coursing through my blood since I was born as a third generation.
Mm-hmm.
This was something, my fourth grade autobiography, my mother saved it, and I had written, I'm going to be an orthodontist. I mean, it's one of those things. And I love this profession, but we have failed at certain things. And one of the things that, as a profession, we have failed at is not providing sufficient education to those who haven't joined the club.
Mm-hmm.
Okay,
Mm-hmm.
going through a formal ortho program and
Mm-hmm.
become certified orthodontist. And I think it's a weakness. It's one of our more embarrassing shortfalls as a profession as a whole. We've been very protectionistic, and it's not. It is what it is. We know why it is. Nobody disputes it.
Yeah.
I wish it had never happened, but it did.
Yeah.
Well-
Because the way I see it, my opinion on that is that I think general dentists would probably not do more orthodontics, but they would see the problems. They would see more problems, and they would probably refer even more than they're doing now. It's just about education. I think a lot of them
start it and learn and stop doing it. Orthodontics is so easy to do poorly. It's so hard
Yeah.
to do well. It takes an awful lot. For the same reason Jerry said in that podcast, the hardest thing he can imagine doing is general dentistry.
Yeah.
For general dentists, the hardest thing they can imagine doing is orthodontics well.
Yeah.
Anybody can.
Well, it's very easy to start cases.
Yeah.
Very easy to start cases. Finish them is something else.
Yeah. Well, and the
To
misconception.
our satisfaction. Yeah.
The misconception or the marketing from certain clear aligner companies is that the clear aligner thing, that's really simple. The fixed appliances, the metal and stuff, that's difficult. But the clear aligners, that is really simple.
Clear
It's a
aligners
tool.
are great for really simple cases, or for even some modest cases, like a moderate case. But they like anything else. It's a tool. It's not the only.
It's a tool.
Okay, and there are certain. Look, the research is there. Certain things, movements, clear aligners don't do well. They just don't. They don't rotate cuspids well. Okay, they have issues with dealing with the vertical. They do. Okay, it's the limitation of the appliance.
And Stefan, what's your answer to that?
I agree with the vertical.
It's
You
tough
read-
to- it's
No,
tough
but I
to-
think that
tough
the
to
misconception
with clear aligners.
misconception also with clear aligners is thinking that, and we hear that a lot in the marketing of some of the brands, is that you don't need any attachments, you don't need any elastics. The aligner will do everything. The software will do everything. You can accept your cases with your eyes closed, And I think this is where it can be dangerous because, again, it's just a tool. It's a tool. If I'm good with that tool, if that tool in my hand is better than using braces, then perfect, good for me, good for my patient. If I'm better with braces than with clear aligners because I'm more comfortable using braces, then use braces. It's just, but what I always say is that the teeth are not selective.
Yeah.
They don't care. They answer to force, time, and space.
Yeah.
That's it.
And distance.
And
And distance.
and then Newton's third law, like you said. That's it. I mean, for every action, there's an equal and opposite reaction. That's it. So you want to take some, I had a teacher at university said, you want to take peanut butter to move your teeth and you're able to control your peanut butter, then use it.
My father said he could straighten teeth with chicken wire and tire tubes if he knew what he was doing.
Yeah.
Yeah. Well, Larry, Stefan and I both expected this would be a unique, delightful experience.
No,
Really, it is. I mean, we could go on and on and on and on. It's just, yeah. Thank you so much.
We'll do it again sometime.
We have to. I'm sure there's going to be a lot of a request for that.
Larry, one of my thoughts as I've aged is that it's impossible to maintain meaningful friendships without admiration, and you are someone I admire.
Thank you. Thank you.
Thanks a lot for your time and expertise, Larry.
All right.
Thank you very much. It was, we want more. I need more.
I said live long and prosper.
Like this? Hey,
me
thank
see.
you very much.
One more time, Larry. Here you go.
Yeah, let's do it all together. No.
Yeah. All right. Bye-bye.
Bye-bye.
Thank you. Thank you very much. Bye. This is an episode you should listen to again and again and make your staff listen to it. Another example that the odd couple is where the center of rotation is outside of the box. My name is Stefan Reinhardt, Director of Education for the C.L.E.A.R Institute. Make sure to subscribe to our channel, download our podcast, and be back next time for more interesting and entertaining conversation.